I've just finished my quarantine. If I would have been here a few days early, I would have not shaken your hands. And if you go through it, and Europe has been through a state of fear and paranoia and hysteria at its extreme. I was disinvited of a meeting to a German big development organization because I've been back from Liberia. Would I please not enter their house because it could be dangerous. And so I'm very glad that the Archbishop took up this issue, because I think Ebola really hits the heart of society. Having been twice in Liberia over the last couple of weeks, worked with the Christian Health Association of Liberia, being in a country of no touch, in a society that deeply lives by community, by sharing, by embracing, by being in one household. And I would like us all to get up and stand for a minute and give tribute to the more than 300 health workers who have died. I've just put one picture up, but it's just one name. There are 330 names that you may know, you may not know, and I think it's good before this meeting to remember those who've left their lives, because those are the heroes, and those who are still there serving in those hospitals that have hardly anything. So let's get up and just remember them. I just want to give you a quick update practically from the ground. And I would like to put the issue on hope today. I've been in Liberia beginning of September when everything was a disaster. People were lying on the street, they were dying on the street. There was a health service that was paralyzed by fear. There was a government that was paralyzed by fear. But thanks to many issues, I don't think it's one, it's many things that have happened. And I think today we can talk of hope, not only because the vaccine trial was released yesterday and there's a hope that maybe things will move even in terms of vaccine and maybe later on a treatment. But there is signs of hope, and this has been published by WHO, and I think we can see the figures are going down. I've seen empty beds, treatment units empty, new treatment units being constructed, but hopefully there won't be a patient going in them. But it's no room for complacency. There is still too many patients being seen every day, and you see those statistics. This is from yesterday. For the past 21 days, we can see how they are struggling. There are good days, there are bad days. We still got a long way to go to identify the areas. Still, Monrovia is at the center, is the hotspot of the epidemic. We have worked with CHAL in the Lofa area, and I was really pleased being there in September, coming now, and being in Lofa and seeing what the communities have done and how they have responded. And you can see the local positive results. And, I think it's good for them to also celebrate. They've done a great job, but there are still areas where they haven't been doing great jobs, and it's now moving into the southeast where it's much more difficult to deal with. CHAL has quite a number of health facilities in the southeast. It's very difficult to reach. They are now just starting to work there, and we've got a long way to go. Liberia, positive. In Sierra Leone, we've had just training of community workers there, and there we are still struggling to get on. But I think a lot has happened, and a lot the international community has done. And when at the beginning of September there was such a paralysis and fear, I found now a really well-coordinated response, and thank you to WHO, thank you to many agencies, MSF, I can't name them all, but people are working together and people are doing their best. Beginning of September, you called 4455. That was one person sitting with a small mobile phone somewhere. Of course, couldn't respond. And now we've got a good emergency response. The ambulances are coming. People are collected within less than 24 hours when they are called. So there's been a big improvement. Yes, we have still a long way to go. But from where we were to where we are today, there's a huge difference. And this is just a picture of the data management unit. And I think that is a huge change. And also at the community level, and that's where churches are strong, that's where the churches are working. There's been a lot of work done at the community side. But we have to realize, and just now we had this testimony from Norway, Ebola is a dangerous disease, and it starts like any disease in West Africa, or the most disease. It starts like a malaria, and that's why it's so difficult to differentiate at the beginning. It starts with a typical malaria state. It goes into, in this epidemic, a heavy gastrointestinal state, and then goes into shock. In West Africa, we cannot do the treatment we do. We just had a published report from Germany, somebody who survived. A tremendous effort was done, and this doctor was saved. We have difficult circumstances. We have about one doctor serving 20 to 30 patients with Ebola. We have a PPE that is there, but it's extremely hot. You can wear it about 2 hours, 1 to 2 hours, and you have to change. And so you have to actually do triage. A good publication that has been out now that looks at how do we manage. We manage by self-care, patients, dehydration without shock, and patients in shock. You've got to look, where do you put your emphasis? And it's that middle group where the doctors really need to put their emphasis, and there's a very good training center now in Monrovia running. The doctors and nurses working in these ETUs are well prepared, and it's good to see it's not just Westerners, it's people from Uganda, it's people from Kenya, it's people from DRC, people from Cuba and other places working together. So what is happening at the treatment units is really happening in a good and coordinated manner, and they're getting as good results as there is possible under the circumstances. But then I find prevention is really what we need. And there's a lot of myths still going around, Ebola maybe being transmitted by air or something like that. It is not possible. You need to do exactly what Archbishop has told us. You need to touch somebody, touch the dead, touch the sick, or get in contact with the sweat of the sick. And we do not quite know how relevant it is that in the semen of the reconvalescent patient there is a possible Ebola virus. There's now one patient in India being sort of quarantined, taken out because he's a reconvalescent. But people, I don't think at the moment know exactly.
I'm stopping you because here in your slide you are putting that the virus is in the sweat of sick people.
When they're highly febrile.
This was never demonstrated. It's a wrong message that you are giving here. I'm sorry to stop you because I have seen that and I need to stop that.
Right.
The virus alive is not in the sweat. The PCR is maybe positive,
the PCR is
but
positive.
The virus in the sweat is not isolated.
Okay.
So stop with this message.
Thank you.
The virus is not in the sweat, please.
Thank you.
Thank you.
But in the touch of the sick person, you can transmit the virus.
Nobody has isolated the virus from the sweat of anybody. Is it clear?
Yes.
Okay, so if you don't have the virus, you don't have transmission.
That's right.
RNA
That's what I'm saying, yeah. Only the sick person can transmit, and you need to get into contact with body fluids.
Yes, but the sweat, no.
Okay. Thank you. I think what has really been dealt with very well is that a lot of hand washing has been implemented. I think what we have not seen in 30 years of diarrhea, prevention, etc., really hand washing has been implemented, and there are very creative ways of actually doing it in the community. And I think it's good that prevention starts at the community level, and the community response is of utmost importance. Empowering the communities and families to protect themselves. And this is where the churches have started to work, where they've been very active to really get dignified care and to ensure isolation at that level. Just one example out of a slum area in Monrovia, where communities were mobilized and people are there to do the follow-up in the community of the contacts and of others, and where they have, by their own means, restarting their health services now. Where health services closed in August, September, and they've started to reinitiate those health services. In their being mobilized by a church community, say, let's get our health center restarted again. And then they're using the IPC that has also been introduced, infection prevention control measures. They established a locally constructed triage system so that now patients can come to the little health center, be protected, Ebola patients being selected out, and the health center being able to really treat patients securely and safely. Another issue that has already been mentioned are the funerals, and I'm very glad for the new guidelines of safe and dignified funerals. But in discussing at the community level with the churches, that is a huge challenge for pastors, for imams, and for others, having dignity and respect, because there's not just the physical dimension, so there's a spiritual dimension in how a person is buried. Not only technically correct, but culturally sensitive. And I think we've learned a lot over the last 2 months, having imams and others now really involved in this process of burial. And so we are still finding pockets, and again in a local community, coming into communities where you have barriers. And so what has happened in Lofa County needs to be replicated in every other county. It needs to be replicated in every area in Sierra Leone or in the other areas. And this is a long process, and it doesn't happen in a day. So I think we need to also give people time to learn the messages to be able to go on. We've discussed with WHO in the health sector, and they've come up with the theme of keep safe and keep serving, where we are really looking at the community level that I just described, but then also the health center level, making the health services safe in the area where Ebola is active. And I think this is one of the key issues. The health services in many districts have basically been closed down. Or the health centers, the hospitals, I've seen them, they were empty. Why? Because people are afraid, communities are afraid. People died in the hospital, people died in the health centers. And so that is the issue, that we re-establish that trust into the general health service. So a lot of our effort with the programs we're doing with Diaconie and Bread for the World and others is strengthening the local health system, investing into the local doctors and nurses and making things safe at their level. Training, triage, treatment. And a lot of training has been done, and we have seen it's not just a matter of training people. CHAL has trained quite a number of health workers in various clinics and health facilities, but it's not really just done with doing the training. You have to really restart them thinking, what does it mean to have strict hygiene and protective measures? And they are the key to re-establish the health services. And the observation I had over the last couple of months is, yes, training is done, but how can you ensure that what we train people in is implemented in those services? And so they're starting to putting the IPC focal persons in the hospitals so they can rework. And we've started developing mentoring relationships. So the people in the hospitals are mentored in the way they work and in what they do, so that they are encouraged to keep to these hygienic measures. And I think this will be a long-term effect that it will have on the quality of service that is done in those hospitals. We have construction work that is needed. But we are trying to see that some of the construction work can be really done with local materials, so that isolation areas do exist, that holding areas do exist, and the link to the ETU treatment centers is established. And I think this gives us also a change now to look at sustainable change and change for development. And also out in the communities to create that link between local communities and the local health service. That needs to be re-established. The communities are ready to act, and I think it's necessary we work with the people and not for the people, so that people are sort of involved and they are empowered to do what they need to do. A real challenge is the reintegration after survival, when people come back into their villages, dealing with trauma and loss, the relatives having to re-establish trust. This was a person that was infecting us before and now coming back into the community. Dealing with colleagues. Many of them have lost material things because some people have burned their mattresses, have burned their belongings. Stigma and discrimination is a real issue. And this is another field where the church can really be active and involved. And I think at the community level, that the linkage is done between community volunteers and the health facilities, messages from Ebola prevention to health promotion can be established, and access to health facilities and good services needs to be improved. So it's re-established. What collapsed or nearly collapsed during the summer period is re-established over the next couple of months. Communities need to be empowered so they not have only Ebola at their view, but we also look at the broader view already, re-establishing and improving health services. So our theme over the next month and the next year is then going to sustaining church health services with the Christian Health Association of Liberia and of Sierra Leone, looking at those Christian health centers to re-establishing their services that they are doing. We also like to strengthen the offices for the Christian Health Association of Liberia. It was a weak organization. I think they are learning and they are improving. And so we are looking at long-term interventions in those areas. Thank you very much.